Have you ever wondered how an epidural is placed? Stick around if you want to see a demo. Epidurals for labor pain are typically placed at either L4, L5 or L3, L4, and this tends to line up with the intercrystalline, which is right around where the top of your posterior iliac crests are, which most people typically think of as the top of our hip bones, even though it's not really actually our hips. I'm also feeling for where I think a good intervertebral space will be. Next, we'll prepare the back with a sterile cleaning solution, put on a sterile drape. If this were a real patient, I would be using sterile gloves and a mask and hat, of course. Once I'm sterile, I always double check my landmarks one more time. This is typically the most painful part of the procedure, giving a little bit of lidocaine to numb the skin. Once the skin is nice and numb, it's time to insert the Tuohy needle. This is what we'll ultimately use to thread the epidural catheter. You insert until you start to feel a little bit of resistance. Ideally, that means that the needle is starting to enter the ligamentum flavum, which is just one step before the epidural space. We go very, very slow through this part, and we use a special syringe filled with either air or saline to check resistance at each stop. Once you feel a loss of resistance, that's how you know you've entered the epidural space. Now, we have a few choices here. Some providers will choose to stop at this part and use a spinal needle, which is much, much smaller and a little bit longer to puncture the dura. There's some good data showing that it can help speed along the onset of the epidural and provide pain relief quicker. It's also another good indicator that you were nice in midline. Some patients may also receive a combined spinal epidural, meaning we inject a little bit of numbing medication, the same type of medication we would give through the epidural, through the spinal needle itself to directly go into the fluid that bathes the spinal cord. The benefit of this being even faster onset of pain relief. I will typically do one or the other of these depending on the clinical situation and what I think is appropriate for the patient. Now it's time to thread the epidural catheter itself. Now you'll notice this was a blind technique. I don't have x-ray vision. I don't know where the tip of the catheter truly landed. So we do a few tests to make sure that the catheter didn't accidentally go into the intrathecal space, meaning the fluid that's bathing the spinal cord, or into a blood vessel. Once we're confident the catheter is in the correct place, we will secure it in place so that the patient can feel free to rock and roll during labor into whatever position is comfortable for them. Tape it up, connect it to an epidural pump, educate them on how to use it, and they should be good to go. What questions do you have? Let me know in the comments below.